Welcome to the Veterinary Academy, where we discuss veterinary emergency and critical care and science-based tools for veterinary professionals. The main objective of the right ventricular assessment is to document signs of right heart strain, which may be a potential sign of a large pulmonary embolus resulting in obstructive shock. The RV may be evaluated in different echo views, including right parasternal short and long axis views depicted here. On right parasternal short axis view, RV is smaller than LV, and it has a characteristic crescentic shape because it is wrapping around the circular shaped left ventricle. The RV walls are visibly thinner than left ventricular walls because RV is working against much lower pulmonary pressure. On the right parasternal long axis view, the RV has a V shape. The RV to LV ratio is usually 0.6 to 1. In other words, RV equals to about 2/3 of the size of the LV. Most of the RV systolic shortening occurs in the long axis, as opposed to the left ventricle, which shortens by 80% in the short axis. By knowing normal anatomy and function of the RV, one can detect signs of RV dilation and strain on bedside echo. These signs include the following. First, increased RV to LV ratio. Second, RV may become an apex-forming ventricle on the four-chamber left apical view, which is not normal. Third, due to the RV dilation and strain, it may deflect the interventricular septum towards the LV lumen, causing a D-shaped LV. Finally, RV wall may get thickened due to high strain and increased work. This is an example of severe RV dilation visible on the left apical four-chamber view. In this case, RV to LV ratio is 1.26 instead of normal 0.6. For comparison, the image to the right represents a normal heart with preserved normal ratio between the right and left ventricles. This is another example of severe RV and RA dilation on the subxiphoid view. You can easily appreciate that the right chambers are much bigger than the left. This is a great example of severe RV dilation on the right parasternal short axis view. In this case, instead of having a crescent shape, RV has almost circular shape and causing flattening of the interventricular septum, leading to a D-shaped LV. Okay, now how can you integrate the results of the RV assessment into your ICU practice? If RV size is completely normal, that will exclude pulmonary embolus as a sole cause of arterial hypertension. It will not allow you to completely rule out PTE, but it will let you rule out PTE as a cause of obstructive shock. If you document severely reduced RV function in a patient with shock, you should consider the use of inotropes, pulmonary vasodilators, and other drugs such as thrombolytics, vasopressors, and even fluids versus diuretics in some patients. It is important to reassess response to therapy with serial exams that may add value to your diagnosis and case management.
By the way, you can download the guideline on the acute management of pulmonary embolism in dogs and cats by clicking the link in the description below. If you enjoyed this video, check out more on the VetInCrit channel.